Topics we'll be covering during the first inning of today's baseball game will be as follows. Celmods, I'm going to say those are on deck because if we have a class of meds that are probably coming next, probably celmods. After that, we'll talk about Venetoclax and targeting BCL-2, and I would say Venetoclax is at a 2-strike count right now, and we'll talk about what I mean by that. And then I'm going to just mention a new agent that is in clinical trials, including a couple of sites around Michigan, OPN 6602, which has another unique and completely different target within myeloma cells and cancer cells in general, and we'll talk about that. I'm calling it a September call-up because we just opened the trial right here in the fall. So these are my disclosures. Briefly, I consult for some companies. I do research that's supported by some companies, and I just want to say my spouse is an employee of one of these pharmaceutical companies, and I just want to be transparent about that. She works for BMS, and they make celmods, which is the first class of drugs that I'm going to be talking about. I will do my very, very best to give a fair and balanced presentation regarding all of these drugs, and I also want to be clear, none of the things that I'm going to be talking about are on label or in most cases even approved yet. So celmods are derivatives of a class of drug that we've already heard about. We heard about thalidomide, brand name Thalamid, and derivatives of that, lenalidomide and pomalidomide. These collectively are called, see, yeah, everything, the formatting got changed. I'm scared of the animation, but here we go. These are a class of drugs called IMiDs, immunomodulatory drugs. And celmods are related. These are the two celmods that are in advanced clinical trials right now, are iberdomide, which used to be called CC220, and mezigdomide, or Mezi, we sometimes refer to it, Iber and Mezi, which used to be called CC92480. These are celmods. This is a slide that I used in a talk in Saudi Arabia in 2011. And I loved this slide, and it talks about all the ways we thought IMiDs worked in 2011, and we've actually touched on a lot of these. Dr. Gertz mentioned the effect on blood vessels, and Dr. Pianko talked about the effects on the immune cells, and Dr. Cole talked about the effect, the role of the microenvironment, and IMiDs do actually affect all of those different things. And as much as I love this slide, what it's missing is the actual mechanism of activity that we've now learned that they work by, which is targeting something called cereblon, or a cluster of proteins that includes cereblon. And this is an important part of the anti-plasma cell mechanism of these. And I'm going to, how many people in the room are cell biologists? Right. One. You know, and I hear about it at every appointment, you know, but the rest of us aren't, right? And so I'm going to sort of just walk through how these work, and I'm going to only dive deep with this one class of drugs to sort of establish a theme about how this drug works, because it's relevant to how the other drugs that we're going to talk about work, and you'll see that we're kind of in a, I think that the next groups of drugs are, there's a theme in terms of how they work and how we're approaching therapy. So cereblon is this is a protein cluster which helps regulate other proteins within a cell. And so normally, this is a cartoon, and I'm actually scared to hit click. Okay, there. So this is a cartoon, and basically cereblon normally very carefully selects certain proteins within the cell and targets them, tags them, and drags them over to the garbage disposal organelle in the cell for degradation and gets rid of those. And it leaves other ones alone. It has a certain sort of profile of what it's looking for. And the proteins that cereblon leaves alone include proteins that are important for myeloma cell survival and growth. Okay? And so when you leave those proteins alone, that's a happy plasma cell. It's living its life supported by the presence of these proteins. But when you give an IMiD or a celmod, a cereblon E3 ligase modulating drug, that's what CEL stands for, cereblon E3 ligase, it changes the profile of what this is looking for. So instead of targeting those cells for those proteins for degradation, it targets these ones for degradation. And it breaks them down, and the levels of those proteins go down in the cell. And when those pro-survival proteins are gone, you have an unhappy plasma cell, and the cell dies. Okay? That's a general gist of how these drugs work. Okay? And the degree to which celmods degrade these proteins compared to the older drugs, the IMiDs, is different. So this is kind of the order of their potency, of their strength in causing this degradation, and that corresponds to the clinical activity of the drugs. And so, for instance, we know that iberdomide, which was originally studied in patients who already had myeloma that was refractory, that had progressed on lenalidomide or pomalidomide, that it was no longer responding to those drugs. About a third of those myeloma cases would respond to treatment with iberdomide and dexamethasone. So we know that it is a more potent drug. And again, this is a simplification. It's not simply this one thing, but we know these drugs are being developed right now in the earliest studies. They were in patients who uniformly had these other drugs already. Okay? So we know that they're potent. The way that they're being developed in clinical practice right now is, just to think about it, is iberdomide is sort of being developed to succeed lenalidomide in the places where lenalidomide is currently being used, and I'll show you examples of that. And mezigdomide is being developed in places where pomalidomide is already being used, okay? Which makes a bit of sense because mezigdomide is the most potent drug in this class, and so if you're going to sequence these, if you're imagining a future where a patient might get both at some point in their illness, you don't want to use mezigdomide first, right? Probably or possibly. I mean, so it's this is their development strategy. And so in iberdomide, as an example of sort of the trials that are ongoing, we have what we call the Excalibur studies. Right now, the Excalibur for relapsed myeloma is a head-to-head trial of Velcade, daratumumab, and dexamethasone as a standard FDA-approved control arm versus iberdomide, daratumumab, and dexamethasone. And this is head-to-head in patients who've had at least 1 or 2 prior lines of therapy, who've had 1 or 2 prior lines of therapy. And what they're measuring is what we call progression-free survival. Progression-free survival means the degree to which the myeloma, that a patient doesn't have progression of their myeloma and doesn't die from any cause. They're alive and well without progression of their myeloma. That's progression-free survival. The Excalibur maintenance study is a simpler study, also randomized though. It's iber straight up against lenalidomide as maintenance therapy after transplant. Okay? Head-to-head trial again. And was that the cell biologist listening to the baseball game? No, I'm just asking. Okay, I'm teasing you now. I'm totally teasing you. All right, and so this is just a head-to-head comparison of len versus iber versus len. At Karmanos, and that includes Karmanos in Detroit, Farmington Hills, and Lansing, as of yesterday, Lansing, we have the IBEX trial, which is iberdomide and daratumumab together, not randomized, just both drugs together as maintenance therapy, and it's going to be open at University of Michigan as well. So we're very happy that myeloma patients around the state, wherever you're being treated, hopefully would have access to this after transplant. And we're looking at a different endpoint. We are looking at progression-free survival, but we are also focusing on the ability of this regimen to make patients MRD negative. And actually, we didn't talk about MRD negativity all that much this morning, which surprises me because it's usually one of the main topics that we cover. But MRD, or minimal residual disease, or measurable residual disease, is basically a way of evaluating myeloma after a deep response, right? So when the tests that we use in normal clinical practice can sort of detect myeloma to a certain point, but below that point, standard tests don't pick it up anymore. And MRD testing is a test that we do on the bone marrow, which actually can look for like one myeloma cell out of every million cells tested, sort of level of sensitivity. So you're looking for very, very tiny residual degrees of myeloma left in the bone marrow, and we're looking to see how often this regimen can completely suppress to the point where that test doesn't even detect the myeloma anymore. And then finally, we have the mezigdomide studies. And again, these are a pair of randomized studies in patients with relapsed disease where a mezigdomide-based regimen is being compared to an FDA standard approved regimen head-to-head, where you're either, in the first case, you're swapping out, you're basically swapping out pomalidomide for mezigdomide in a 3-drug cocktail. And in the second study, you're adding mezigdomide to a 2-drug cocktail and comparing it to a 2-drug cocktail, and that's carfilzomib and dexamethasone with or without mezigdomide. So you can see here that, I mean, just these 4 pink boxes, these drugs are in advanced testing. These are studies designed to get the drugs approved. That's what I meant when I said they're on deck. Okay, like if these studies are positive, it's likely the drugs would be approved. Okay. Now I want to move to a different topic, Venetoclax. Venetoclax is an approved drug, but it's not approved for multiple myeloma. Okay? And we heard in passing this morning about myeloma with a T1114 translocation. And what that means, that's done on FISH testing. It's a bone marrow test, and you're using probes to see if chromosomes 11 and 14 in the myeloma cells swapped pieces. And when they swap pieces, it leads to dysregulation of certain genes, and you get overexpression of something called cyclin D1, and you get overexpression and increased dependence on BCL-2. Now remember in the last slide, the cereblon slide that I showed you, I talked about pro-survival proteins, right, that either get left alone or they don't get left alone depending on the presence or absence of that other drug. BCL-2, it's another pro-survival protein. And so Venetoclax, as an inhibitor of BCL-2, takes the knees out of the myeloma cell and renders it and makes it susceptible to dying. And so we had early studies that suggested the utility of targeting BCL-2 was more or less, not 100% limited to patients who had the 1114 translocation, but what this showed us was that, the overall response rate in a study of patients who had had a lot of prior treatments, about 20%, 21% of people responded to Venetoclax with or without dexamethasone. But when you broke it down by whether or not they had the 1114 translocation, you could see that almost all of the patients who responded actually were the ones who had that swap. If they didn't, the patients who didn't have it, the 36 patients who didn't, 6% of those patients responded. So there is ongoing work trying to tease apart, like, well, why did those patients respond if they don't have this translocation? Emory, where Dr. Parikh is now practicing, they've done some really interesting basic science looking at this, looking at like the profile, sort of like the biology of the plasma cells in responders beyond just having or not having this translocation. And so I think it's a work in progress, but right now in clinical practice, I think if a clinician were considering the use of Venetoclax or another BCL-2 inhibitor, they would rationally limit it to patients who have this translocation. Now, I referred to this as having a 2-strike count. So strike 1 was a study called the Bellini trial. This was a study of Velcade, bortezomib, and dexamethasone with or without Venetoclax, and it was a pretty stiff dose of Venetoclax, 800 milligrams daily. And this was for patients who had 1 to 3 prior therapies, and they did not require that this translocation was present. So they were treating patients with or without the translocation. And what they saw, without showing like survival curves and all sorts of like complicated data, the summary was the venetoclax arm had more responses, deeper responses, longer responses, and despite everything you would think based on that information, shorter survival. There was negative effect on survival, and it really had to do with infections. It had to do with toxicity. And so this was a negative trial. Survival was favored the control arm of this study. Now, subsequent analysis raised the question about whether that would have been the case or not if you had just limited it to patients with the T1114 translocation. Maybe you were just treating a lot of patients who didn't really stand to benefit and still had the risk of toxicity. But Strike 2 was the Canova trial. And the Canova trial was a head-to-head study of venetoclax dex versus POM dex. That was the study. Randomized study, and this study did require the 1114 translocation, and once again, better responses by any measure that you looked at, number of responses, depth of responses, duration of responses, it all favored the venetoclax arm over pomalidomide. But then when you looked at the duration of disease control, progression-free survival, it actually didn't differ between the two arms. And so that was the primary endpoint of the study. It missed the primary endpoint, so it was a negative trial. That's Strike 2. I suspect the real baseball fans in the room have already left, but for the people who are still here, what do we know about 2 strikes? You're not out yet, okay? So venetoclax, I would say, is not dead, but venetoclax has not been off to a good start, in multiple myeloma. It turns out, I think our best chance for a hit with venetoclax might be AL amyloidosis. AL amyloidosis is a different plasma cell disease related to multiple myeloma, but the problem with amyloidosis is the abnormal plasma cells are making bad protein that gets deposited in your body tissues. And the biology is different besides that because the 1114 translocation is 2 or 3 times more common in AL amyloidosis than it is in myeloma. So you have a much larger percentage of patients with this disease who could potentially benefit from venetoclax. And also, unlike myeloma that has a list of approved drugs that's this long, this has 1 FDA-approved regimen for it. Everything else we do for AL amyloidosis patients is a derivative of what we've learned from myeloma. So there may be room for this drug to be developed in this disease. And this is a graph of a single patient. The red line that dips down to 0 at the end, that's their disease marker, their kappa-free light chains. And you can see that the kappa-free light chain levels were elevated throughout the first 4 lines of therapy. And then when they started venetoclax and daratumumab, their light chains dropped down to 0, and they had an improvement in the function of organs, their heart and kidneys, that were affected by these protein deposits. So it's anecdotal, but it tells us that you can get responses with this drug in this disease. And then a subsequent study that looked at 12 patients with an 1114 translocation and amyloidosis, 7 out of 12 patients responded to venetoclax-based combinations. Now, some of them were getting it with bortezomib, some of them were getting it, I think, with dara or lenalidomide, but they were venetoclax-based therapies. So we have a ways to go, but I think this might be the place where venetoclax finally, breaks through. There are several ongoing trials that might help us with this. There is an ongoing venetoclax and dexamethasone trial. The one I'm more excited about is Ven-Dara and Dex because daratumumab is even more active in amyloidosis than it is in myeloma, and they play in the sandbox well with each other. So this is an ongoing trial right now. Venetoclax ixazomib, which is an oral analog of Velcade. It's an oral proteasome inhibitor. That study is ongoing. And then another exciting trial, which is an international collaboration using a different BCL-2 inhibitor that's still called ZND5, unless Maury or somebody else knows of a new name. But this is a more potent, more selective, more precise targeter of BCL-2. And this trial, is, again, being done internationally and has already finished accrual. And we've seen from the early reports that patients are responding. There was about in the first report, there was about a 40% response rate in terms of light chain reductions in amyloid patients, but we don't have like the long-term follow-up yet. And finally, I have one slide on this last topic, OPN 6602. Here's a target we have not touched on at all today. EP300 CBP. What the target is not as important as what targeting it does. This is a new oral agent. It's taken, I believe, daily. It's being developed as myeloma therapy, but based on the mechanism of action, it may actually be useful in other tumors too. It's being studied in mesothelioma, which is a tough asbestos-related lung cancer, and it's also may have utility in prostate cancer. And it works in a general way by messing with the 3 R's. You remember the 3 R's? Reading, writing, arithmetic, right? So it messes with that. That's how it targets cancer cells in general. It interferes with the cancer cell's ability to read, edit, duplicate DNA. And as we heard about from Dr. Gertz at the beginning of the day, if you can't copy your DNA, you can't repair your DNA like you can't with alkylating agents, cells die. Also, you can't produce proteins that your cells may need, and in myeloma, specifically, you get downregulation of a protein called MYC, and you also get downregulation of a protein called IRF4, both of which are important for myeloma survival, and MYC is overexpressed in a small subset of patients at the time of diagnosis, but as disease progresses, that tends to increase, and so it becomes a more relevant target for heavily pretreated patients. And right now, there is a phase 1b trial of this drug ongoing. It's open in Detroit and Farmington Hills, and it's also open at a center in Grand Rapids. So it is open across the state of Michigan, and so there are multiple places where you might be able to have access to this. And with that, I'll leave you with these take-home points. We've made progress in myeloma therapy. Survival is 3 or 4 times longer now than it was when I was Dr. Parikh. Okay, we've made a lot of progress, and we're putting patients in remission. When we were treating patients with thalidomide and dex as upfront therapy, less than 5% of patients went into remission using the technology that was available at that time. Now we put like 90% of patients into remission, and more than half of them are MRD negative with good induction therapy. So we've made major improvements. Matt Pianko used the word revolutionary, a revolution when we were talking about immunotherapy, and it's true. It is a total paradigm change, but we're not actually just in the immunotherapy era. We're moving into the post-immunotherapy era where many patients who've had BCMA-targeted therapy have already moved on to second immunotherapies like talquetamab and need therapy beyond that. And that's where these molecularly targeted agents that we're working on now, this is the space where these are going to be so important. So identifying new targets and figuring out how to actually get at them is going to be the key. And then, as Dr. Cole said, importantly, making sure we actually test these drugs in everybody and that everybody who needs them has access to them is going to be a key to the development of these drugs and ultimately succeeding broadly in myeloma. And that's what I got for you. Thanks.